Empathy is knowing our own dark
Words
psychology.
have power. Like
Without that connection, you don't have anything.
What's the opposite of addiction?
This freedom.
Well, hello everyone. Welcome back to another episode of Finding Peaks. My name is Brandon Burns, Chief Executive Officer for Peaks Recovery Centers, joined today by our Chief Medical Officer, Dr. Ashley Johnson, and our Chief Operating Officer, Mr. Clint Nicholson, everybody. Welcome back, everybody who's joining us today. As we spoke about on the last time I hosted, we were going to invite Dr. Ashley Johnson in to talk about a variety of issues surrounding patient care in the direction of major depressive disorders. We're going to do what we can to stick true to depression as the topic today. But if you know how this show works, if you catch us going out in different directions, you already know how it works, and for those who are new, this is how it works. So, so here we are today. On top of this, not just our Chief Medical Officer, and I think I just want to highlight, really what that means for, Peaks Recovery Centers. You came into Peaks and showed us a variety of different ways about how to improve patient care. Not only did you introduce and bring on board detox services for us so that we could do a continuum of care through Peaks Recovery Centers, but you were really the anchor and the flagship for us developing integrated care whatsoever, making mental health primary, a significant feature of programming and creating that inclusion, as well as us having to kind of punch through the door of medication-assisted treatment and move through those kind of attitudes at the time. So she's done an incredible amount of work on behalf of Peaks Recovery Centers that we are super grateful for. At the same time as well, too, she's branched out and created Colorado Recovery Solutions, for which she's the CEO and founder of as well, too, and we'll get into more of what those services include in that regard. But a lot of fantastic things happening that you're a part of, and I think for the viewers out there as well too, you all know me. My job here is wanting to disrupt an industry, and I think Dr. Ashley Johnson here, I'm just going to go to Dr. J because that's what we call her at the office. Dr. J here is a big part of this disruption, and I think in a really beautiful and vibrant way. And so we're going to tackle these topics today and get right into it. So through your vision at Colorado Recovery Solutions, what do you see as needing to be disrupted from an industry perspective? And I'm sure that's a loaded question, and maybe there's a lot to dive into there, but I think maybe at just a high level in a general sense, what are you seeing through the lens of psychiatry that is not working, for which you wish to change moving forward?
I think what I see most and what drives me the most is what a lot of other psychiatrists are seeing too, is just this exciting kind of emerging field of neuroplasticity and neuromodulation. And so that is what really drives this kind of changing the path of our approach. So for decades, it was just medication. We had to wait for the next new mechanism really to come out, especially with depression, which is one of the most debilitating mental health conditions. And so we've just gone through probably every decade since the 50s. We had a new mechanism of action come out, and then it wasn't until the SSRIs hit the market that, and probably around 1990 or so, was Prozac. It came out first, and then Zoloft was soon to follow, and they are amazingly still the standard first-line medication. However, what we have also found out over the last 3 decades is that you can't expect full remission of symptoms, especially with depression. And SSRIs are first-line medication for many different psychiatric disorders, PTSD, OCD, generalized anxiety. So all of those are really kind of top of the list that we see especially when you come into peaks. And, because we have now this primary mental health, I guess, kind of track, it's not only treating someone who has a primary substance use disorder, but we have to think differently about it. And so because depression is probably the most common mental health condition, we are going to see a vast majority of primary mental health patients who come to peaks for stabilization have major depressive disorder. And so it just makes sense that we look at the next best treatment past medications. And that has now emerged as TMS, or transcranial magnetic stimulation. And
I'm glad you said it, because
Yes.
I was like, how do I say TMS out loud here? Don't mess it up, Brandon, but you have the language, so that's perfect.
it took a lot of practice to get that one down. And then I just went back to calling it TMS. So
It's a safe place for me too.
yeah.
Yeah.
Right. So I look at this emerging field of really neuromodulation as kind of really two different emerging categories, and one is TMS and one is ketamine. And there's a couple different forms of ketamine now available. First, it was just your basic generic ketamine that was first used for anesthesia, and it's a very short-acting anesthetic, dissociative anesthetic, and so for, again, decades we were using it, and then just incidentally found that it had an extremely potent antidepressant effect. And so then practitioners started noticing this and said, well, why not just go ahead and let's refine this medication and give access to the psychiatric disorders, really, people who are suffering where we haven't made a whole lot of improvement, again, since the SSRIs came out. And then that was primarily for depression, where we saw people really just coming back into their own after a ketamine, I guess, dosing. And then over time, we also found that through understanding the bioavailability of ketamine, is that infusion is the best way for people to get the best effect and the most exposure throughout their body from ketamine. And so that's why, for the most part, if you want an extremely effective version of ketamine therapy, you want to do infusion. And so infusion, I guess if you said infusion versus Spravato, which is the nasal spray that just came out a couple years ago, and is still on patent, of course, is much more difficult to access that medication. But the bioavailability of Spravato as a nasal spray it's actually S-ketamine, which is just a slight change in the chemical makeup of it, and different from your just basic ketamine. Ketamine is 100% bioavailable through infusion, whereas S-ketamine or Spravato is 50% bioavailable through nasal spray.
Okay.
And so that you can kind of associate the differences in its effect based on that bioavailability. So because when you deliver that drug through the nasal passages, it has to go through many different stages of processing through the body where it actually degrades it, whereas infusion can bypass many of those kind of filters in your body to where you get much more effect from it. So
You brought up, if you don't
Yeah,
mind me
go
interrupting,
ahead.
if you brought up two really interesting concepts that I think are worth kind of mentioning again, which the idea of neuromodulation and neuroplasticity, and I'm wondering if you could speak to that a little bit,
Yep.
just for the audience, so that they recognize, because those concepts, like you mentioned, really have sort of changed our approach and kind of our understanding of what the ability or capacity for long-lasting change and recovery actually really looks like in somebody's day-to-day life. So I'm wondering if you could speak to that from the psychiatric standpoint, what the importance of that concept of neuroplasticity and neuromodulation really is.
Yeah, absolutely. So really, it's not so much that that concept is new from medications. However, it seems new because these treatments that I've mentioned, and as well as even better understanding about psychotherapy or talk therapy, as well as your traditional oral medications, like we mentioned, the SSRIs, all of those actually have an effect on your neuroplasticity if done correctly, right? It's just some are more effective at it than others. So that's where TMS and ketamine come in, is that they really kind of showed up on the stage here as having a neuromodulatory effect on the brain that could cause a faster healing process, basically. We were seeing the effects faster than if you did long-term psychotherapy, even CBT, that's time limited. If you did, by the book, 12 sessions in 12 weeks, and then you did occasional follow-ups for CBT, you could see the effects, similar effects, if you did 6 infusions of ketamine in 2 weeks. And so if now what we're finding is that the neuromodulatory effect is so much more improved if you have a ketamine infusion or even Spravato or even oral ketamine while you're doing therapy, right? So now we've combined it all. And while there are lots of therapists out there doing that, I don't think we quite know yet the impact of this and how positive it's going to be, and just so much more effective. That's what's so exciting to me about it, especially absolutely for treatment-resistant depression, but especially for PTSD in that regard.
Yeah, I think that, Brandon spoke to you really sort of creating this interdisciplinary culture at Peaks and establishing that through a really robust medical program, but it's the integration and sort of the collaboration of the clinical world and the medical world where we really start to see where we can have the most efficacy as far as change and sort of taking advantage of the sort of neuromodulatory effects of treatment. And it's what makes this very exciting, these types of collaborations, and the fact that this is new to a degree. At least the concepts may have been around a while, but our understanding of them has improved. Our ability to approach them in a fresh, more innovative fashion is also really improved. And then when you bring the two worlds together, you get this sort of exponential impact, which we're just now starting to really to kind of explore and see how that works and how that engages and really does improve the treatment of clients and just quality of care in general. So it's pretty it's an interesting and fun time to be a neuro nerd, basically.
It is.
Yeah, it really is.
Absolutely.
And for me, I think the brain is the new frontier. It's the final frontier as far as our understanding of everything about us as individuals and how we work and how we function. And so bringing in these kind of new or kind of more innovative approaches to treatment is really exciting. So.
It is.
Yeah, absolutely. And you gave, I'm curious because I'm hearing neuromodulation and neuroplasticity, and at the end of the day, how we might be able to simplify it through a metaphor and what that healing mechanism actually looks like. And you gave a beautiful presentation and training opportunity for staff a few weeks ago as well too around this subject, and you in describing the neural pathway and what was happening, I think you brought up the metaphor of a rope and it being frayed. And if that still is applicable here and has context, I would certainly love for you to re-review that metaphor on behalf of the viewers, so that we could bring these big encyclopedia-style terms into something that's a little bit more palatable.
Yes. Try to get it down to less than 5 syllables in the word. But so I love that metaphor of if you were to kind of take your, a piece of the brain and kind of smush it, and you would see all the different nerves, or even throughout your body, and in neurons, which are kind of long and like a rope. And so what we had talked about was that if you take a big rope, like you might see it at some port somewhere around ships and things, and you just kind of take something rough like a brick or whatnot, and you just rub it on the rope really hard, like a hemp rope, and you'll start to see the fibers start fraying, right? And so those frayed fibers on this rope really represent what your neurons can look like if you have suffered from an untreated mental health condition for quite some time, like years. So absolutely, major depression, generalized anxiety, and PTSD and OCD all fit into that category. They can all really, when they're untreated and they go on for years, they actually are assaulting the brain in different areas of the brain through the different hormone cycles that are being released, and neurotransmitters are dysregulated and that kind of thing. So like all the chemicals and such that are swirling around the brain, they are so dysregulated that they're actually assaulting the brain. And so they will, those conditions can over time kind of almost shrink parts of your brain, again, if it's untreated. And so that's why it is so important to intervene early in these processes. If we can, assign the diagnosis, figure it out through someone's history, and then we can come back to what we described as this rope. And by applying even the medications we talked about, the SSRIs, or the psychotherapy, TMS, and ketamine, when all of those are applied appropriately, those frayed fibers from the rope are kind of like smoothed out. It's almost like you are pouring a substance that kind of clears that rope off of the, like a wax is a good analogy as well. So then once you go and you pour the wax on the rope, you can't feel those fibers anymore, and that's really what your nerves will then look like as they are healing if you were to look at them under the microscope, once you have undergone some of these treatments, right? And especially if you achieve full remission, meaning all of your symptoms go away, and you kind of return to full functioning in your life.
The English major in me just loves the metaphor, so yeah.
Absolutely. Yeah. And as a philosophy major, I was always told not to use metaphors. I think it's a great metaphor in that regard as well too. So there's so many different branches we could fire off from here on, but I think flat out speaking, somebody comes in with a major depressive disorder before we were, as a medicalized system or through the lens of psychiatry really looking at these opportunities. It was just medication, right? And when it was just medication, or assuming medication moving forward, there's a reason in which we kind of want to move away from it, and that reason to me seems to be that there isn't a great there isn't a significant probability that all individuals will get well under medication, that at some point it feels like we're throwing darts in the dark in that regard. So before diving more into these unique value propositions that you've created and brought into Colorado Springs, and certainly supported Peaks patients through Colorado Recovery Solutions, what is the efficacy of medications in the direction of major depressive disorders at this time?
What we can expect is about 30% of individuals that try any one of these first-line medications, so SSRIs, which again is Prozac, Zoloft, Lexapro. Those are the common ones that people are prescribed. Maybe 30% of those people who are prescribed those meds will get 30% improvement in their symptoms of depression. And then it continues down the line. If Prozac, Zoloft, Lexapro, if it doesn't work, standard of care is that you would then either try a different SSRI or you would switch classes of medications. And that typically in our traditional psychiatric prescribing world would mean that you would go to an SNRI, usually is most common. And so that would be your Effexor, which is venlafaxine, or Cymbalta, which is duloxetine. You might somewhere in there try Wellbutrin, which is its own unique mechanism. It's a stimulating antidepressant, and so if you have anxiety, you don't typically want to use Wellbutrin, but it can be a potent antidepressant in and of itself. And so generally speaking, you would go down that kind of algorithm of decision making if someone doesn't respond at any one level of that or any treatment there. And so every time you fail a medication generally means that you have less of a chance of getting better with a new medication. It's still worth a try, generally speaking, because medications, oral medications, meaning by mouth, are the side effect profile with SSRIs and SNRIs, again, are all those I just mentioned. The side effect profile is very low, generally speaking, at least in regards to if you are weighing the risks and benefits of, do I go on continuing to suffer from depression, or do I try a new medication? The benefit does outweigh the risk of the side effects, or even the fact that it may not work. So then, so that's really the cycle we've been on for 30 years or so.
And this is we didn't talk about this prior to coming on here, so feel free to just say we didn't talk about this, we're not talking about it. But it reminds me of like when I think this is how Tylenol works, right? Let's say I have a headache, right, because of dehydration. I'm not aware that I need to drink more, but I have a headache. So in American culture, one of those quick external strategies isn't to explore, hey, did I drink enough water today? It's like, no, I have a headache, Advil, or Tylenol, and I prescribe that for myself over the counter in the moment, and I give it to myself. It's not clear to me that when I take it that I've actually resolved the core issue, that the medication is in fact, at least in the way that I'm perceiving it right now, is just distracting me from the fact that I still have this ongoing headache because I have not drank enough water. And if that's true about how those work, at least in those moments, as a distracting feature, how much do those medications, when they're working, are they working in a similar way of where they're not actually smoothing out the rope in the way that ketamine infusion and TMS is actually doing? Is it more of a distracting feature and it's still frayed, or in time is it actually smoothing out that rope, if all that?
Yes, that's a great question. So the way I would look at it is, and what I tell my patients is, when we're starting an SSRI or an antidepressant in general, is that this is not just a patch. It is a neuroregenerative medication. And if you take it consistently, which is every day for the most part with all of these medications, you have to take it every day. You have to allow your body to reach a steady state of the level of the drug, and then allow it to remain at a steady state level for weeks before you will get the optimal effect on your depression or anxiety. And during that process, it is actually stopping the assaultive process on your brain's nerves. So it's like taking that brick or whatever it was, this razor blade, that whatever was scraping across this rope and fraying it, it's like it's removing that from the process.
Gotcha.
It's stopping it. but it may not be, at least not in the immediate sense. It's not pouring the wax over the rope to smooth it out. That takes probably at least a year or more of you taking the medication consistently, really doing consistent psychotherapy.
So there's no neuromodulation taking place. It's just it's taking the brick away and then allowing the rope to stay there. The distracting feature of the medication is that I no longer experience the fraying, the major depression and that sort of thing, but in time, because we have these natural cellular, remodulation that'll take place independent of all these things, in the background it's slowly healing itself now. Whereas under the new lens of like ketamine infusion, for example, it's an immediate remodulating of the neuron there, right?
Yes. It still requires repetition of the infusion, but and then it still may require boosters of the infusion over, the following year or so, but it's quicker. And so, like with the medications, the oral medications, it's like taking, if you were going to pour wax over the rope, right? It's like taking a candle, a tiny little candle that's burning, and you do like one drop. Yeah, and if you had a rope like as big as this room, that would probably, could easily take a long time. Yeah, a couple years easily. Inconsistent therapy and medication to achieve the healing that you might achieve through TMS or ketamine. And so with TMS actually is, right now we think that you can probably achieve double the effectiveness of medication with a 6-week, actually it's about more like 8-week trial of treatment with TMS.
So speaking of the time frame that it takes, because we have a 45-day residential program in which medications are first line of defense. We usually start those immediately. However, seeing the efficacy of those take effect is going to take weeks sometimes. And we only have 6 of them, right? So we start the medication right away, the clinical interventions start right away, the psychotherapy, the sort of traditional intervention strategy happens right off the bat, but we know that's going to take time, and that is the healing mechanism at that point. So we have a shortened model, we have a shortened amount of time, and now we have these new interventions or more interventions that have become more accessible. Is it appropriate then to start ketamine or start TMS right off the bat in order to kind of almost as a jump start to that process? Does that make sense from a medical perspective? Okay.
It does, and I don't think of it as, well, if you look at our detox model of care, right, where it fits in the continuum of care for substance use disorder treatment, it's the first week of treatment about, right? So it's removing the substance, helping keep someone comfortable until they can kind of get back to somewhat of their baseline, right? They're still going to need to go through a few weeks of stabilization in the residential program, but having removed the substance that was also assaulting the brain is stopping that process. And then we're kind of in the clear, is how we look at it, medically cleared, basically to then apply these other treatments that are more rapid in their effect while someone is participating in the group therapy, the individual therapy, especially at Peaks and the model of care that we have there. We also can start the oral medication at that time too, because ketamine, S-ketamine or Spravato, TMS, they all work as augmenters of the oral medication as well as the psychotherapy, right? And so instead of, let's say we have someone who comes to us with treatment-resistant depression and suicidal ideations, which is pretty common, in order for them to really be able to bypass going to the hospital for that to stabilize. These new treatments, especially ketamine, can help stabilize someone like that so that they can continue in the program, and then with repeated administrations of the infusion or Spravato, it actually is helping propel them into healing. And so it does work really seamlessly together, and should at least. Right. Now, our systems may not, our financial systems and such,
I was going to get
might not help us with that.
A little disruptive for a second, because knowing what we know about the efficacy of these treatment interventions and strategies, the access to them does not necessarily align with what our treatment trajectory would look like, specifically within this timeline, this sort of chronological timeline. We want people in right away. And insurance companies are not necessarily allowing that. And I'm just curious, want to be curious with everybody, why that is and what we can do within our industry and as disruptors of this industry to try to change that through sort of collaboration with organizations like yours and companies like yours, like CRS. So as a psychiatrist, what do you think is our best strategy to make these changes and make them known?
So I'm someone who, my first approach is to just comply with whatever they tell me to do in order to get my hands on the treatment or be able to give access to my patients, is I just do what they tell me to do. And so that's what I'm doing right now, and kind of have, and just now have fulfilled many of these requirements from insurance companies, from the FDA, which, you know, a lot of those kind of things from the FDA, and what Spravato is controlled by is called a REMS program. So that stands for Risk Evaluation and Mitigation Strategy. And so that's overseen by the FDA, the DEA, and Janssen, who created Spravato. And so we, in order to provide Spravato to any given person with major treatment-resistant major depression and or acute suicidal ideations, we have to comply with their program in order for the drug to be safely administered and not diverted basically into the community. And so that's one approach.
We encourage that approach for
yes,
sure.
Right.
Yes,
safety first.
Yeah, absolutely.
100%. I truly
absolutely.
believe that.
Yeah, 100%.
And so, but then come the insurance companies. So how do you comply with everything they want you to? Because they all have different standards, despite different interpretations of the studies, the literature about these different treatments. And so they impose on us all their different criteria, or agendas. I look at as, what's that?
Agendas, some might call them.
Yes, yeah. The almighty dollar is always looming there somewhere. So, so in my approach, I learn their game. I learn basically how do you give access to these treatments in their most effective manner according to the evidence that we have for them, and then how do you advocate to the insurance companies on the behalf of your patients so that when they're denied, which all of these, ketamine infusion aside, that it is not covered by any insurance because many different reasons. It's generic, it's been around forever. There's no patent for a company to really take it and advertise it to all these different companies and such. But that is really, if you think about it, while ketamine infusion is invasive in that it's an IV, 50% more bioavailability and really effect, probably, potentially, versus Spravato, should suggest in our culture that, you know, we should be supporting this treatment, really, and trying to get this one out because it's affordable, more affordable at least, than Spravato. So, but insurance has embraced Spravato. They cover that. But we have to, of course, go through this prior authorization form for everything that I've mentioned, TMS, Spravato, even med management at its basic level. We have to go through these, at least, figuring out the benefits and such, and the millions of different plans and such. But it's in the times when you spend a lot of time with the patient, filling out the prior authorization, you submit it, you think it's a slam dunk of a case. This person has just been suffering for years from treatment-resistant depression. You've justified all that through all the med trials that they've gone through the duration of their major depressive episode, and then it's possible through some technicality that's written in the insurance policy about TMS or ketamine or Spravato, that they'll say, oh wait, no, we don't agree with that. The overlap of when you tried Lexapro was 1 month outside of what you documented as the current episode of depression. And so we don't count that as a medication trial. And I think you have to really get up to speed on all of the literature so that you have to kind of go into a debate with the other physician on the other line who is saying, no, this doesn't qualify. I'm going to go ahead and deny this, and you can just barely keep them from hanging the phone up on you. And then if you do get your point across with them, they still say, without any kind of basis for it, sorry, we're just not going to approve this today. You need to either go to an appeal or resubmit it, or sorry, you're just out of luck. So that takes hours out of your day.
Yeah. And the whole time the patient is still suffering.
Absolutely.
Yeah,
and the risk is mounting.
Absolutely. Yeah.
For how debilitated they may be from their depression, if they're suicidal.
Yeah.
What may happen. And these are people who are not in the hospital, but we're trying to help keep them out of the hospital.
Which ultimately saves insurance companies money. So there's this element of irony to it all. And the fact
there is.
And I think I'd like to talk about it because this is the world in which we live, right? Mm-hmm. This is the access to care that is, we have these new and amazing intervention strategies at our disposal, but not necessarily always accessible. And that is, and that's frustrating. And I think it's valuable to talk about it.
Yeah. Oh, 100%. And from my frustrations, of course, and all the episodes I've done around treatment centers' websites, hope and save, and all these words have behind it a great deal of complexity to actually bring the individual forward, so which now they start feeling hopeful. And this is such a wonderful discussion, but for the sake of time, for sure, because the kids on the social media only have so much attention span. I think they've all walked away now with the rope, with the rope analogy. So I think we got that much across in this moment. I just wanted to, before I take us home and out of this room, for at least for this time until you come back with Jason Friesma in the following week. How long does it take? Is it neurouptake? I forget the language of. When you take an SSRI, say, it's Zoloft or Lexapro, whatever the case might be, how long does that actually take before the individual, for the 30% that it may work for, how long does it take for them to actually start experiencing that? Is it immediate? Is it weeks? What does that look like?
We generally just tell people to expect, at least 4 to 6 weeks before you get the max effect of the dose that you are currently taking. You might feel some effect in the first week or two. It's very possible, but it's not going to be the full effect. And then at 4 to 6 weeks, you if you don't have full remission of your depression at that time, you always want to look at would the next higher dose be indicated here. And usually it is. Usually you just go on up if you haven't had side effects to the drug. And if you have had side effects and they're still going on, the standard of care is that you have to wait that out. So you can't go up on the dose unless you're just willing to accept that those side effects may get worse, and then you have to wait it out again. It can become a very strenuous, laborious process for any one person who's suffering from depression or extreme anxiety even, to have to wait that out, and then if it doesn't work on the first go around, to have to do it again and then give up if that one doesn't work. We do have augmenting strategies we can try. Sometimes that does help it kind of take control a little bit better, or take effect. Not all levels of medicine, and at least practitioners, are comfortable doing the augmentation strategies with different medications. But so again, access to care then becomes another risk with medications. And so, and then access to care in regards to TMS and Spravato is so much more difficult to achieve. Then your risks just continue to mount, and the suffering continues to mount, really. And the vast majority of people don't have, money flowing out of them to just kind of, pay out of pocket for any one of these treatments. And for instance, Spravato, if you paid out of pocket for that, could be $1,500 in administration. Jeez. And so you could have, easily, I'm calculating in my head what maybe the average of someone, how many administrations someone might have to actually stabilize on Spravato, at least 8 in the first few weeks. And so who can afford that?
Yeah, absolutely.
They're already paying for their health insurance,
right? So
they can barely afford that, and then it doesn't oftentimes cover it. So yeah, it's a dilemma.
Yeah. Well, I think that so one of the things that I just want to challenge viewers on, especially in relationship to addiction treatment centers, even mental health primary centers, when you get to all of our brilliant websites, we are stating we treat things like dual diagnosis. And dual diagnosis as a category could be, I have a major depressive episode taking place right now, and I was smoking pot 6 months ago, or maybe engaged in some other abuse around drugs and alcohol, but this is the primary issue of concern. And our admissions lines are always so passionate to bring people in, to be the opportunity, to be the treatment episode that provides these services. But I think for me, and the caution to the wind here is that if our only shot at this is to, dole out medications, SSRIs or otherwise, that we have a fairly limited opportunity to actually treat what we say we can treat at the end of the day. And that really resonates with me and calls upon treatment providers watching this, aware of this information all around the country, to proactively move in the direction of the creation of these advanced services. And on top of that, or these services through Colorado Recovery Solutions that Dr. AJ has brought to the community here in Colorado Springs, and certainly been supportive of our patient demographic coming through Finding Peaks, that there needs to be these alternatives. And that what we can also hear out of this discussion is there is a whole insurance side of thing and payment platform and a fragmentation that is ripe for disruption in this regard in a really big way, because it is in the way of, okay, now we know meds aren't going to work, or it's going to take 4 to 6 weeks, but the person's suffering right now. And how do we get ahead of that in this moment? So I think it calls upon all of us to do a better job to lean into these types of resources and where we're going. So kind of to recapitulate what's going on, it seems like the problem within psychiatry, at least in the past, has been kind of just waiting for the pharmaceutical industry to create something for us, and then to get behind it, and then hopefully there's enough money behind it for the insurers to come in and say, okay, well, we'll provide this, and that we can't wait anymore. Mental health and depression and anxiety, especially over the last 2 years, are just skyrocketing exponentially among American citizens and certainly around the world. And so we're in the need of new solutions. And through platforms such as Colorado Recovery Solutions that Dr. Jay here has created on behalf of this community and is working with Peaks Recovery Centers to defragment our situation, seems like the new opportunities and where this is headed, for which we should all be excited about, but slightly discouraged by the amount of time it may take to actually get all of this to come together. So at the end of the day, thank you so much for coming on and talking about this with us. It's a really important topic, especially around depression, PTSD, generalized anxiety. There are solutions that are out there and available to the community and through treatment centers like Peaks, but at the end of the day, the situation is extraordinary, and it calls upon all of us to do better and to have these discussions and to represent what the limitations are so that people can appreciate why these solutions exist and where we're headed as an industry. So on that note, as always, signing off here at Peaks. Find us on Finding Peaks at peaksrecovery.com. Dr. Johnson here is going to be on next week's Finding Peaks episode as well. So if there's more questions, thoughts, ideas that you want to ask in her direction, please let us know about that so we can address that at that time. Certainly won't be the only episode. I think we could go on for weeks about these topics in general. As you all know, Chris Burns is doing awesome, fun videos on the TikTok. Follow the Peaks Recovery TikTok page so you can hear loud screams of recovery and energy here. A little bit different than the discussions that I'm generally having. Again, the Facebooks, the Twitters, you kids all know what's going on out there. Thanks for being with us and being patient as we describe these technical and detailed issues that are going on, especially around depression. And until next time.